Morning, morning. Hopefully, we are live. Had a couple of little hiccups this morning. Um, let's just wait to see if there's any messages coming in. Yeah, that's looking all good. Well, how you doing, mate? Good to see that. Yeah, looks like we got a few eyes in this morning. Morning, David. Yeah, all good. Thank you. Why is that saying that? That's not right. Let me just change that. Yep, a couple of little hiccups. There we go. Let's save that. I obviously didn't save it. So we haven't gone back in time. It's not episode 230. It's episode 231. We are back doing the muscles of the hip and the pelvis. So we're going to divide them up into different sections. So they're a bit easier to learn, easier to kind of compartmentalize and go through. And we've got the hip rotators that we're looking at today. And if we do get a bit of time extra as well, maybe into the posterior part of the thigh as well. I've got loads of stuff going on in the background of my screen. Just get rid of all those distractions. There we go, get rid of that. Right, okay, let's get going. So, morning Tris, how you doing? I saw a really cool thing today. I've been saying for years that scans are really useful for obviously looking at anatomy. Not very good for looking for symptoms. And then the Asaf Weissman today, or Wiesman, I think. I can't don't know. I've never met him, so I don't know how to pronounce his name. So apologies, Asaf, if I've got that wrong. He posted this thing about MRIs being used to highlight inflammation in joints, which is really cool. What a great kind of start into looking at the causes of nociception. So that was really interesting today. I need to do a little bit more reading about that. Yeah, I agree, David. Yeah, definitely. Good Instagram post from Tristan recently. So yeah, if you've not had a look at what Tristan does, it's Move Massage Pro on Instagram, and puts out some really good content. Give him a follow. It's worth following. Right, let's get you going. Oh, I can tell everything's just not in sync today. That you can see the hip and the pelvis is quite a large area. There we go. So that was a quick reverse preview of what's coming up. Nothing like teaching live, is there? So we're going to have a look first thing at the bursa. This was an interesting thing, because when I first learned about especially hip pain on the side of the hip, which we'll talk about in a second as well, then it was always a bursitis. It's like, trochanteric bursitis. So we'll have a look at that and some other possible reasons why people might have symptoms there as well. I did do a whole session on tendinopathies a little while ago, so might be worth having a search for that if you've not seen it before. But I'll talk a little bit about it as we go through some of the pathology around this area as well. Anyway, so bursa then. If you've never really heard of a bursa before, we don't have any images on the cadaveric specimens, because they dry up during the preservation process. So we don't really see them in the labs unless you have what we call a wet specimen. There's no better way of putting it, but somebody who's had a light fix. So had some specimens like that at Glasgow University when we were just there, so that they get a you get a better view of what it's like in real life. But if you've had something that's set in formaldehyde, then with that kind of really strong fix, then we don't really see them. But there are loads of them. And so if we have a look around here, so this is your greater trochanter. So we were looking at this the other day, and we're also looking at the ligaments around the hip region, and the whole area is covered in these little pockets. So a bursa basically means a purse. So it's like a pouch that has bursal fluid in it. It's not synovial fluid. It's a specific bursal fluid, and it provides a friction-free barrier between surfaces that would be causing friction. So if we have a look at some of the tissue around here, so we've got several layers of muscle, which we'll look at over the course of today. And in between each of these layers of muscle, we have these bursas. They can develop as well. So we have areas where they're usually located, like in most anatomy, we have a kind of usual pattern of things. But then depending on the activities that you do, or the kind of lifestyle you lead, you might grow or develop more bursas in different places. On scanning, so when we're looking at these on imaging, especially with the ultrasound scanning, you shouldn't really see a bursa because they shouldn't be inflamed, and it's only when they're inflamed that they start to grow and you can see them. So ideally, on from an ultrasound point of view, you shouldn't really see them. They're very, very thin structures. Just going back to your point, MRI detect inflammation of muscles. Could that be the case for it? Well, they've only done it on the spine as far as I know. That's what I saw this morning. I haven't really read into it any more than that. So but yeah, I'm guessing it would be able to identify inflammation anywhere, really, which would be amazing. There's because this is the thing, and there's been a whole debate as well about on the Sports Therapy Association page recently about diagnosis, and I think we conflate injury and pain together. So when somebody has injured tissue, there are certain things that you can do to try and identify the injury, but that doesn't necessarily identify what is causing the person's pain. So I think that's hopefully this kind of advancement in imaging will help with that, because if you have a chemical irritation via inflammation, then it is very likely to initiate a nociceptive response. So it's going to be quite interesting watching that unfold. But yeah, so these, so if we have a look at the location of these, so we've got in between the muscles, and then over here we've got another bursa where a muscle crosses over. So if you have a look at the name of it, we've got iliopsoas. So you might have heard of that before. It's two muscles that have a conjoined tendon, and they come over this region here. So there is a bursa that sits underneath that muscle, so that it reduces the friction as it comes over the pelvis just there, and then attaches down here. So that's what these bursas do. This is when they become inflamed. This is a cracker. This is a olecranon bursa, so the elbow point, and often this one often called student's elbow. So when you're studying for a long period of time and you're resting on that bursa, on that elbow point, then it creates irritation, and then it starts to swell, and you get something like this. Any bursa has the potential to become inflamed, and then you get a bursitis. Okay, so but yeah, bursa is basically a purse. It helps to alleviate the frictions in some joints or between different anatomical structures. It's usually between something and a bone. Okay, so where there's a immovable object and then something that's gliding over it, that's usually the case. They do look a little bit like a joint capsule, but like I said before, they don't have any synovial fluid in. They have bursal fluid. They've got a thick fibrous outer layer and are filled with bursal fluid, and they cushion the movement between structures where a lot of movement takes place. So the way that I demonstrate this in a live class is if you rub your hands together, then it causes heat in between your hands, and you can feel that heat. But then if you put something in between it, I can do that all day, and then there's no heat. Yeah, so it reduces the friction. So if basically that's like what a bursa is. Okay, so you put something in between that's going to protect the structures from rubbing against each other, and that's basically what's happening. So if we have a look at some of the bursas around the hip and the pelvis, so already we've looked at some of these from the first image, but we also, oh yeah, they've got a trochanteric bursa, but which one? There's not just one bursa, so it's not just this one here. Yeah, and again, you might see this in some books or hear some people talk about this trochanteric bursa, but there was a study done. Let me just move me out of the way. So this was back in 2008. It's the morphology of the bursa associated with the greater trochanter of the femur. There were 18 cadavers that they looked at. So there were a total of 106 bursa that were identified in 10 different locations. Average of 6 bursa per hip. 4 bursa were present beneath the glute max muscle and the fascia lata, which is the band that comes down the side of the leg, including those normally thought of as the trochanteric bursa and the gluteofemoral bursa. So again, the words, if you link them together, you can see where they're coming from. So we've got glute and femur. Yeah, so in between the glute and femur. 2 bursa beneath the tendon of the glute medius muscle, the anterior subgluteus medius bursa, and the piriformis, so the posterior subgluteus medius bursa. There were loads of them. In the majority of cases, a single bursa was located deep to the glute minimus tendon, although 2 different bursa were identified, the subgluteus minimus bursa and the secondary subgluteus minimus bursa. They've got to get some better names for those. They should have named them the Woodley bursas or something. Okay, so there are loads. Yes. Get the impression hip bursitis is overdiagnosed, often tendinopathy overlooked. Absolutely. Yeah, that's the big problem. But it's because of what you're taught. So if you're taught that if there's pain there, then it's the bursa, then yeah, unless you do a little bit more reading around the area, then it doesn't present itself to you, so you diagnose everybody with that who's got lateral hip pain. So it's very common for people to be misdiagnosed with that. There's lots of reasons why people will get tendinopathy as well, and we'll discuss that when we have a look at the tendon in more detail. So this is a really good picture of the multiple layers of bursa that are in between each of these structures. So all of these here. Yeah, so all of the different muscles that are attaching onto the greater trochanter, pretty much every single one has got a bursa in between. How are you going to know? You're not going to know. Yeah, you don't know how many someone's got, whether they've got multiple. So instead, an average of 6. Yeah, so that's what we're going with around that kind of region. Then we got this one, which was at the front, which I pointed out on the original picture. So got iliopsoas bursa just at the front here. Also sometimes called the iliopectineal and iliofemoral. And again, break up the words, ilium, femur, ilium pectineus. Yeah, so that we've got a bursa between the ilium and different muscles. lies between the iliopsoas tendon, so the iliacus and psoas conjoined tendon, the superior pubic rami, which is the branch of the superior part of the pubic bone, proximal medial aspect of the femur, so bit closest to you and on the inside bit of the femur, also cushions the tendon from the anterior hip joint line, or the tendons from that region there. So it may not be in a specific place. There may be a couple, maybe a bit bigger, spread over a bigger area. So again, another thing to consider when we're looking at diagnosis in the anterior hip. Maybe there is a bursitis. Okay, maybe it is a tendinopathy. It depends on how it's presenting. Okay, and then we've got all of these around here as well. Okay, so this is a posterior view of a right hip. There's your ischial tuberosity. So you have a bursa on your ischium. Yeah, so your bum bones between the glute max and the ischial tuberosity. And so obviously stopping the friction between those bones. Trochanteric bursa, remember there were loads of those, so not just the one, and then gluteofemoral bursa. So the gluteals, which we'll have a look at as we go into the muscles of the hip, they attach onto the IT band. So where the glute comes over, there is a bursa, or likely to be a bursa, underneath where it attaches onto the femur as well. Okay, so there's loads of them all around. The diagnosis of a bursitis is often, like I say, misdiagnosed, because it could be friction, but in my experience and from what I've read, it usually has to be, especially for greater trochanteric bursa, has to be like fell on, like an impact to cause that a kind of irritation to the bursa usually. Okay, but again, it's the friction kind of stuff, because that kind of goes in, doesn't it? If you think it's just friction related, then there's been an increase in activity, so you think it's friction on the bursa, but then you image the bursa and there's nothing there. Have a scan, whatever, there's nothing picked up. So the other things in that area are all the tendons. Yeah, so where the tendon is, again, depending on the story, is the more likely outcome. So 10 muscles in and around the glute region, and we've split them into different groups. So we've got 6 deep posterior muscles. These are like the rotators of the hip, so like the rotator cuff of the hip. 3 gluteal muscles, and then the tens fasciolata all around that region. Okay, so that's your kind of brief overview of what's coming up. So first thing I'm going to have a look at is the rotator cuff of the hip. So these are the deep posterior muscles around that particular region. So your first one is called the gemelli muscles from Gemini, which means twins. They have a similar location for both muscles and the same action. So it's basically like they're mirrored, and that's why they're called gemelli, however you want to pronounce it. So there's 2 of them. There's a superior one, so obviously this one's above. And if you remember, there was we talked about this quite a bit last week. I can't believe a week's gone. It's been really quick this week. It's your ischial spine just here, because there were ligaments that attached onto that ischial spine as well, and there's a muscle attaching from there and then onto the greater trochanter. So you've got ischial spine, medial aspect of greater trochanter, and muscles can only shorten, so they can only contract. So if you have a look at the line of pull of this muscle, then as it contracts, as it shortens, it will have to be involved in laterally rotating the hip. Okay, now this is kind of the start of debunking piriformis syndrome, because again, when I was taught 20 odd years ago, if you had pain around that kind of posterior aspect, and it was quite deep, then we used to call it a piriformis. Oh, it's your piriformis that's the problem, and it was blamed for all sorts. Now, as we go through these rotators, you'll see it is impossible to blame one muscle. Yeah, so there is no way, and especially with feeling around this area. So look where that one is, and then we'll have a look at where all the other rotators are. They're all very, very close to this region. So being able to palpate through someone's glute maximus, through their skin, through their fatty tissue, their subcutaneous fat, and then down deep into this posterior gluteal area, there is no way we could identify just one muscle. So we've changed the name to be a little bit broader, and instead of piriformis syndrome, it's now called a deep gluteal syndrome. Okay, so is that useful? You do the same kind of treatment whether you think it's the gemelli or whether you think it's piriformis. So it doesn't really change the treatment. But I think it's a better name to give it because it's less specific. Yeah, we can't be that specific. And then here's your inferior. So remember, superior is along here, attaching just about there. The inferior is here. Yeah, so again, we've got around the ischial spine area, so it's a bit of a continuation of the ischial spine, onto the medial aspect of the great trochanter. Twins, yes, one above, one below, both doing pretty much the same job. So let's have a look at the gemelli, however you want to say it. Okay, so just pause that there. Right, we got a lot going on. So at the top here, piriformis, obturator muscles. We haven't looked at these yet. Another obturator muscle just there. We have looked at this. This is your sacrotuberous ligament. So I've labelled that one up there. Ischial tuberosity just here. So if we remember, it's going from the ischial spine onto the medial aspect of the greater trochanter. Look at all that stuff that's going on in that region already, this deep gluteal region. Okay, there is a lot going on, and then we're going to add some more muscles into the mix. There they are. Okay, so there's the gemelli superior. Okay, just up there. Again, look how close these structures are to everything else, and then there's the inferior, just there. Piriformis just above. Obturators were just underneath. Yeah, so there's your attachment points, ischial spine, just on the top of the ischial tuberosity. Yeah, so those are your gemelli muscles just there, and then they're attaching onto this intertrochanteric crest. So if you remember from last time, there was an intertrochanteric line, and the line is flat, well, it's slightly raised, and the crest is a bigger raised area. So the intertrochanteric is, there's your greater trochanter, there's your lesser, so that's in between the trochanters, and it's a crest because it's raised up a bit. Okay, so that's where it's attaching, right on that intertrochanteric crest. But again, this is just the start of looking at how much stuff is attaching in that area. So that's that one just there. Okay, so the next one, these are pretty cool because of kind of where they both have got a similar kind of name. They do slightly different things, but yeah, it's you can see where they come from on different parts around this obturator foramen just here. So we've got obturator, and remember, obturator means to close. Okay, so it was that's the obturator nerve, is to basically works all the adductors, innervates all the adductors to close the legs, to adduct the legs. So obturator internus, we've got a internal surface of the obturator membrane, so it's all on the inside there. But then, do you remember there was a little notch down here? So we had the greater sciatic notch up here, then the ischial spine, and then the lesser sciatic notch just here, and that's where your obturator internus comes from the inside of your pelvis over that notch and then onto your greater trochanter. Okay, so that's your internus. And then the externus, it's the best kind of image I could get of it, is on the other side of your membrane. Yeah, so we've got the external surface of the obturator membrane. If you remember that from the other week, that was the membrane that fills the hole of the obturator foramen. Yeah, so there was that hole, which in a skeleton it just looks like a hole, but there is a membrane there. There's like an interosseous membrane, and it's an attachment site for these two muscles. So you've got internus on the inside, externus on the outside, kind of either side of that obturator membrane. And then it goes onto the trochanteric fossa. So there's a little dip of the greater trochanter of the femur. Yeah. So let's have a look at those. So this is internus first. So this is the internal one. And again, think about what we've already covered: the gemelli muscles, just pop that there. There we go. Okay, and the and now the obturator muscles as well, and where they attach, all in a really similar location. So this obturator internus is on the internal part of the obturator foramen. So this is the inside of your pelvis. There's your pubic bone just there. There's your sacrum, sacrotuberous ligament, sacrospinous ligament just there. So these are the holes that are created by the ligaments and those notches in the bone as well, in the pelvic bone. So there's the greater sciatic notch, there's the lesser. So your obturator internus filling that membrane and then passing through that notch. So what, and the hole that's made by the ligaments that we looked at last week. So there it goes there. So it's filling all that area. There's your ischial spine. And then it's, yeah, so it's attached to the inside of the obturator membrane. So all around there. And then it's going to feed through that lesser sciatic notch. And then come all the way around. So this is round the back now. So there's your sacrum at the back. Greater trochanter. And there it is coming through there. Onto intertrochanteric crest. Yeah. Cool pathway, that one. That one's really good. And then this one is externus. So this is on the outside of the obturator membrane. So here we go, and there's externus just there. So there's your pubis. There's the obturator membrane, or what would be there. That's where externus attaches to. And then it comes underneath. And then there it is coming through there. Okay, so underneath the hip joint and then onto the intertrochanteric crest again. So again, like everything's really close around that area. Hence why we have this this issue with being specific with piriformis syndrome now. Cool. Talking of which, piriformis basically means it's shaped like a pear. It's a bit more bulbous on one end and it's quite thin on the other end. It attaches onto your sacrum and then comes through the greater sciatic notch. So this is where, I mean, it's the classic entrapment for sciatic nerve. And when we get onto the nerves around this region, you'll see that there are lots of different pathways of the sciatic nerve. There's actually a classification system for all the different pathways that it can take. So the sciatic nerve will come through the greater sciatic notch, and obviously it shares that space with the piriformis. And depending on the anatomy of the sciatic nerve, it could go over the piriformis, it can come under it, it can go through it. Okay, but the sciatic nerve is actually two nerves, and that can be split as high up as here. Yeah, so you can have two nerves, two sciatic nerves running down your leg, and those nerves can go one over, one under, one over, one through the piriformis, one through, one under, both over, both under. Yeah, so there's lots of different variations that sciatic nerve can pass through these this structure, and that I think is probably why the piriformis has been blamed for a lot of issues. So that's the pathway of it. Let's have that's what it looks like. So from the front, this is a good view. So that's the front of your sacrum, and then it passes through the greater sciatic notch. So around this area here, there's your ischial spine, and then it comes onto the greater trochanter just there. Okay, so it's passing through that way. So let's have a look at the piriformis. Here we go. Okay, so let's just pause up there. So quick orientation of where you are. So this is the right side of the pelvis, ASIS up here. There's your pubic bone, there's the greater trochanter, there's the lesser, that's your ischial tuberosity, there's the obturator membrane. This is your sacrum, just here, there's your lumbar spine, just there. Okay, so all right side looking at the front. And there's your piriformis coming through there. So there's the greater sciatic notch. That's the attachment point on the anterior sacrum, and there it is coming through there. If I just pause that there. So this is the hole created by the sacrospinous ligament and the greater sciatic notch just there. Yeah, so we've got this foramen here, and then there was this one down here that we looked at earlier. That's where obturator internus comes through that one. Piriformis comes through this one, and it will attach onto your greater trochanter. And let's have a look as it comes through the other side. So now we're going to spin round. There it is coming through there. So there's the greater sciatic notch, and there it is just there. Okay, and again onto the intertrochanteric crest. Another one. Okay. And I think we've got one more. Yeah, I was going to say we've got one more to go. So there are 6 of these deep hip rotators altogether. This one's a pretty chunky one, and compared to the rest, because if you think about the obturator gemelli, they've all been quite thin. This one is quite wide. It's called quadratus, so it's like a square shape, like a quad, right? And femoris, to the femur. So we've got this quadratus shaped muscle that attaches on you around by the ischium, and then onto pretty much the whole intertrochanteric crest. So this whole region here. So remember when we were saying about the bones getting bigger because of the muscle attachments on them. This is, you can just see how many muscles attach onto that intertrochanteric crest. There's loads, and they're all hip rotators. So they've got a vital role to play in the movement and stability of the hip. So that region there is going to have a lot of force through it from day to day walking, running, whatever you're doing. So it's going to pull on that line of bone and create this crest, more so than the front, where we don't really have anything attaching around the front area, so it's nothing like we've got here, not the amount of muscles that we've got here. So this intertrochanteric crest is a real hotbed of attachment points for these muscles. So let's have a look. We've got I've got quadratus femoris video here. So quadratus shaped, square shaped basically on the femur, and it's your last of your hip rotators. Well, small hip rotators anyway. So there it is there, look. Okay. Again, fills quite a big area. So ischial tuberosity, the ischial ramus is where it comes from, and then attaching onto the intertrochanteric crest again. Got obturator externus underneath, obturator internus, gemelli. So these are all of your lateral rotators all together. Let me just play that again. Okay, there we go. So you've got piriformis, obturators, obturator externus underneath there, quadratus femoris. So that's the deep gluteal region. Okay, so hence the deep gluteal syndrome. Anybody with any kind of discomfort there, it's going to, especially around this area here, it's going to be virtually impossible to identify what the specific muscle is. Okay, so that's why we call it deep gluteal syndrome, because it's literally all of that space in there. Cool, so those are all lateral rotators, and that's that one. So that's your rotator cuff of the hip. Okay, now we're going to split the posterior aspect. What time is it? We've got a bit of time, so we'll split the posterior aspect into two parts. So we've got a hip section and a thigh section. So up in the hip section we'll look at the glutes, and then in the thigh section we'll look at the hamstrings. So first thing we're going to have a look at around here is the glutes. So we've got the gluteus maximus, and this is obviously the biggest of the glute muscles if you have a look where it attaches, and I think is often overlooked actually. So we've got, if you remember when we looked at the bony landmarks, we had these gluteal lines that were on the ilium, and that's where your gluteal muscles will attach. So we've got a glute maximus, a glute medius, and a glute minimus. And we've got these lines here, so you can see that one. The posterior line is obviously where this one's attaching onto, and then it comes onto the sacrum as well. But the interesting bit with this is around here, in terms of pathology, around here and down here. Okay, because this is often kind of overlooked. So we've got an attachment point for the glute maximus into the iliotibial band, which we've looked at when we looked at the knee. We will have a look at it again because it's obviously relates to this. So we've got an ITB attachment, but then there's also attachment on the femur, directly onto the femur, via something called the gluteal tuberosity. And if we have a look, it's roughly, IT band is 75%, so all of that. And then the gluteal tuberosity is 25%. So there is basically a ridge on the back of the femur where the glute attaches. That is a real common hotspot for pain, yeah, and classic for the confusion between a bursitis and a tendinopathy, because they will often, well, here's the thing. So when someone comes into you, if you deal with people in pain, they will say, oh, I've got a problem with my hip, and they will tap the side of their hip here. The good thing is their hip is nowhere near there. Yeah, their hip is, well, it's on the front, but it's around here. So when people have a problem, because people then worry that they've got an arthritic hip, and that presents like what a patient would usually call a groin problem. So they'll say they have a problem with their groin when it's the hip, usually. Okay, so if they're pointing to the outside and that's where their symptoms are, then it's usually a tendon issue, like a gluteal tendinopathy. So that's a good thing, because people will have Googled hip pain and then it would have come up with all sorts of hip pathology. But this is a gluteal tendinopathy issue, potentially. Okay, so something to think about when people come into you and say where their symptoms are, because if they're pointing to the outside of their hip, then it's not the hip joint. The hip joint's a lot more medial. So here, oh yeah, that's the other thing. So if you have a look here, the tendon isn't just here. The tendon's up here as well. Yeah, so the tendon attaches into the bone. So the muscle tissue is in between, and there's tendon here and there's tendon here. This bit can become tendinopathic as well. Yeah, and that can be a really, really hot spot for symptoms. And again, it's gluteal. But here, people will say it's a lower back problem. Yeah, so and then they'll Google it and they'll think that they've got disc problems and facet joint problems, but their symptoms, and you can reproduce their symptoms by pushing into here. Then it's much more likely to be a gluteal issue. Okay, so although palpation isn't great, a lot of the time it's really, if you can reproduce someone's symptoms and that's what they feel and it's in this area here, it's the glutes that are there. Okay, it's the glutes that are, amongst other rotator muscles underneath this one, but the glutes are here, the glutes attaching onto this gluteal tuberosity. Yeah, so again, if it fits into the whole story, then hopefully that will help you with working out what to do with people. So look at the attachment point for this one, all here. How many people have that dull kind of ache? And when they say it's their back that's sore, it's all here. Yeah, it's all on the posterior part of the ilium, which is where your glute medius attaches. And then it comes down onto your greater trochanter. Yeah. Remember what else attached around here. So there's your intertrochanteric crest. So we've got glute medius attaching onto there. You had piriformis, you had the obturator, you had the gemella, you had the quadratus femoris. Look how much stuff is attaching onto this area right here. Yeah, so it's no wonder that there's a lot of forces coming through this area and it can become irritable. So we've got greater trochanter, the lateral aspect is where your gluteus medius, so the middle size glute, will attach, and then the smallest one is here. And again, that ridge of attachment there is a real classic. They'll literally, people will like push into the side of their hip, which isn't their hip, it's their pelvis, and that's where they feel their symptoms. It's all around this area here. Yeah, and again, an attachment onto the greater trochanter. So we've got all of these tendons attaching onto this bony lump just here. As a rule, can we say that local pain on palpation never occurs where the pain is referred? So is that if the pain is referred to that point and you push it, it shouldn't hurt? Is that what you mean? Because if there's only one thing going on, then yeah. But yeah, if you're pushing somewhere and they're going, oh yeah, it's sore here, but you push it and there's no symptoms, it can't be, or it's less likely to be, the superficial structures that are irritated. Yeah, it's either a referral into that area or something deeper that you can't physically touch. Yeah. So for example, I had someone the other day, and this is a classic, the deltoid tuberosity just here, and that is a common referral spot for the supraspinatus tendon. So I examined the deltoid, had a poke and a prod around, did all the testing for the muscle, scanned it, and there was nothing that we could see. But then when I poked and prodded onto the supraspinatus, it referred into the deltoid tuberosity, and that reproduced their symptoms. So yeah, it can be a bit confusing because that's where they feel the pain, but there's, well, in this particular case, I didn't think it was coming from there. And you can have exactly the same with the glutes. The gluteals are interesting because they have a referral pattern, which and I say pattern is not always the same. This is the problem with trigger points, and where the old book was an X marks the spot. The problem is X doesn't mark the spot, but the referral pattern still exists. Yeah, so if you follow the Trevan and Simmons book and you go, yeah, that's where it should be, and you poke it, prod it, and there's nothing there, it's basically that it's that region that can be symptomatic that will then refer, rather than an X marks the spot. So that's where the studies around trigger point have kind of fallen short, because they've used a specific point And when you're treating people, it might not be at that specific point. It might be slightly lower, slightly higher, a little bit more medial, whatever. Yeah. So, but in this region, if there is symptoms and you push it, it often refers down the leg. So and it will go down the back of the thigh and sometimes down to the ankle. Reproduce symptoms from here, so that's useful for people who've had MRIs, and they've had all the neurological testing done, and they can't find a reason for these neurological symptoms because they thought that it was coming from the back. Sometimes it's coming from the muscles around the hip, yeah, and you poke and you prod around there, and you can reproduce their symptoms. So that's a good check for things. Cool. Right. Let's quickly do this one, and then and then we'll call it a day. So glute maximus. Hopefully, yep. So let's have a look at that one. Just going to pause that there. Oh, no, not. Pause that there. There we go. Something's gone funny with my controllers. So there's your glute maximus there. So there's a bit of a gap at the front. Yeah, so that's where glute medius fills that gap. Glute minimus is underneath. So this is the posterior aspect of the ilium. And then there's your iliotibial band, greater trochanter's under there. And this bit is the hot spot. Yeah, so it's really, really common to get like so tender all around this area here, and that's your gluteal tuberosity. So definitely worth checking that out for anybody with those kind of lateral hip symptoms. So yeah, posterior ilium, so it's all the way around there and onto the sacrotuberous ligament there. So that's where your glute max will attach onto, and then it will come across. You can see the fiber direction. There's the greater trochanter under there, and then the gluteal tuberosity underneath that bit just there. So there's the glute tuberosity. It's just underneath your greater trochanter. Yeah. So little clinical tip for you when you're doing your assessments. Have a look at that spot. Okay, cool. Let's go back to that one. Get rid of that. Done. I think there's quite a bit to cover around the hip and the pelvis in terms of muscles. So we might be at this for a few weeks. We'll do a little bit of a recap next week around those hip rotators and the into the glutes. If you've got any questions, then you can pop them into our Facebook group and be happy to answer those over the week. I'll do a bit more reading about this MRI stuff as well because that was really interesting. But yeah, otherwise I will see you guys next Monday, 10 o'clock. See you then.